Yeah, thank you, Mr. Kuschik, for this kind introduction. And thank you to the participants to join the webinar, today's webinar. As indicated, we talk about diagnostics and what advantages near-infrared transillumination will have for caries detection. As a short overview, I will just go through caries diagnostic methods in this webinar. I will explain the functionality, the indications and classifications of the diagnostic findings. We talk about clinical cases and conclusions which were already published in studies. And we also talk about the practice integration, and I sum it up at the end with all the key points being mentioned. Now let's start with the caries diagnostic methods. This might be an overview you have never seen before. It is just something which is based on the products, the aids we know we take in our daily practice to just get better insights, to get better diagnosis. And I categorize them into something like inspection, visible inspection you do with probes or with photos, so you don't. These are means which do not measure anything. They are based on your clinical experience. And the second category is you see below are something like non-imaging techniques or measuring techniques. In this category, I summed up devices which use different technologies, but also you don't have something like documentation where you can see where you did the measurement. And last but not least, it is just the imaging techniques. In this techniques, we will discuss X-rays. We will discuss the diagnostic technology, which is the topic of today's webinar, and some other technologies like fluorescence or a combination of different technologies. What do we know about these different technologies? Coming to the category of visually inspection, we know from the visual inspection that it has got more or less low sensitivity if it comes to interproximal detection. Occlusion might be better, especially the studies being done with IC-DAS, so this international gas detection categorization is, while not that bad, it's very good for occlusal lesions, but for interproximal, the assume you might not see under the contact point from an occlusal view, they are not that good. When it comes to a probe, we know that it has got also not very high sensitivity, and can be damaging, as if you place the probe with too hard force, too high force on the tooth, you might damage the tooth, and you can transduce caries bacteria from the surface to a little bit other regions where you don't really want to have the bacteria. However, we have to say it's fast and easy. It's based on your clinical experience, and to be honest, this will be the mean also in the future. Just having a quick overview of the patient, of the tooth status, and all other things are aids which help you and make your diagnosis much more better. In this category, I've also put in the so-called fiber optic transillumination. You might have seen that I mentioned it with Difoti. I will come a little bit later as well. Fiber optic transillumination is a very, so to say, old technology. Maybe one of you places the uses the KaVo dialogues or Lerche probe, or sometimes also polymerization lamps are used for that. And you put them interproximally, and you might see then dark spots. It works pretty fine then with approximate caries lesions. You might not see too much around fillings or on occlusal surfaces. And as I explained already for this category, you don't have an image and you have got not really a documentation. I mean, it will be hard to place the probe and then have a photograph on it. There are much more convenient methods, meanwhile, on the market. Coming to the second category, the so-called non-imaging techniques, measuring techniques. One of the most important one in this category is the Diagnostic. Diagnostic has got a long term of experience now, over 20 years. We launched, or KaVo launched the product in 1999. And when you look at the at PubMed or other sources for studies, PubMed, I think it lists a few hundred of studies with Diagnostic. They all prove that it works pretty well. So we have got a high sensitivity and high specificity for this device. However, we also know that it is plug sensitive. So basically, we use fluorescence effects with this device. So meaning we beam in a laser light inside the tooth, and the caries bacteria with the porphyrins or the metabolites send a responding light to this fluorescence light or to this wavelengths, and this responding light, the fluorescence, we can measure, and this corresponds with the depth or with the depth of the cavity. However, we also know that it is plaque sensitive, meaning we also have in plaque some porphyrins which might then get to false positive readings. This is, of course, we have to avoid, and therefore we strongly recommend to have a tooth cleaning before, in order to just remove stain or plaque from the tooth and get right positive readings. One additional drawback is just you can use it for approximate detection, but it's not that easy. So the main indication when we launched it was mostly to occlusal surfaces. Approximate detection, there's a special tip you might use, and it's a little bit tricky to get a reading out of there. So you need a little bit learning curve to use this also in for interproximal lesion. However, it is a valid device. It is easy to use. You can carry it around. There is no computer connection required. So this makes it very convenient in your daily practice. There's another device in the US I would like to mention over here, Caries ID, which also uses fluorescence effects from Dentsply in the US. The next, I'm not pretty sure if it's still on the market. It's the so-called electric caries monitoring. It uses another effect. It uses the effect that caries has a different resistance against currency. So you put a currency on the tooth, and then you have a second probe, and then you measure the resistance, the current resistance of the tooth. It works good for occlusal lesions, and it does not work for proximal lesions. The background on that is that you need a little bit connection of the surface to the caries lesion. Otherwise, it's more or less you are isolated. So, and this is the case when you place it on approximate lesions. If it's just because the approximate lesion comes from the neighbor tooth or behind the contact toilet of the neighbor tooth, and then you're not able to measure it from an occlusal point. That is why it does not work. Some users also complain that it might be time consuming. Coming to the next category, these are the imaging techniques. Everybody knows it's the gold standard for caries diagnostic is X-ray. We know that as it is very good, we can see inside the enamel, we can see inside the dentin, but we know also that it is not that good for early caries detection. We know also that it is more sensitive for interproximal lesions than for occlusal. And we also know that there might be some overlappings. I just pointed them out with the yellow arrows. And on the right ones of the yellow arrows, there are overlappings. And this is the problem that that's not really a safe diagnosis possible if you just get this overlappings. The next technology, our topic of today, is Di40/Diagnocam. Di40, a few words about that. Di40 stands for, as we learned already, 40 stands for fiber optic transillumination. And by adding digital imaging with that, is that you get the advantage to get a documentation. You have got a live video, you can just do monitoring. Di40 was a technology which was before Diagnocam. Diagnocam is now on the market since 2012. And this is more or less the successor of the Di40 technology. Di40 used a different wavelengths. We added the near-infrared wavelengths to the Diagnocam. Di40 used a lower wavelengths. What that means and what the advantages are, I will show you a little bit afterwards. We know, as a summary, it works pretty well for interproximal occlusion lesions. We can detect caries around fillings, we can detect cracks, and as I pointed out for the fluorescence light, it is less plaque sensitive than with the fluorescence light. So tooth cleaning doesn't have this negative effect. Of course, you should do tooth cleaning before, but tooth cleaning or plaque doesn't have this negative effect resulting in false positive readings than we saw with fluorescence light. I've summed up some other technologies in these categories. We're talking about fluorescence, which, as I said, works good for occlusal lesions. It is not possible to look inside approximate lesions. It has the reason for that is that fluorescence technologies, or especially the imaging fluorescence technologies, use a very short wavelength, and this wavelength is not able to just get inside the tooth. That is the biggest problem. So on the surface, on occlusion surfaces, they work pretty well. As I pointed out, they have got some plaque sensitivity. I mentioned some technologies here. QRLF was one of the first ones, quantified light fluorescence. We have got Fondure, we have got some examples, we have got Vistacam IXHD. It uses fluorescence and with different tips. We also have near-infrared light transillumination, but the infrared light is placed from occlusion surface, so from occlusally. So it's a little bit different technology. With an intraoral camera, we have got Acteon, SuproLife, which also uses fluorescence in a combination with an intraoral camera. I would like to also mention the Caries system, which uses a completely different technology approach. It's called the photothermal effect in combination with fluorescence. Just to avoid questions, yes, there are other technologies coming on the market. We've seen that last year and this year, especially that devices which do dental scans for 3D scans. These cameras are also added sometimes, like Trios from 3Shape or Planmaker Emerald. They are also added to transillumination possibilities. However, it is questionable especially if you use the device in different locations in your practice. If you just put the device, for example, in the prophylaxis and let your dental hygienist do these, just going through the mouth, so we check up with that. It might be debatable if this is the right collocation if you want to do this at the same time dental scan. So it's nice, it works, but higher experience with this technology is with that. Okay, now the big question, how does it work? The function principle is very easy. So this is the tooth, and you see with the red ring over there, you see that there is illustrates caries decay, and you put the camera on top of it. It has arms, and the arms transilluminate the light through these arms inside, through the bone, inside the tooth. And then the tooth transports the light. The tooth transports the light as it is used in this case like a light pipe. Light pipe you know from your dental instruments. You have got producing light, a light source at the one end, and you have got the light coming out to shine on your tooth on the other hand. And this light pipe principle the tooth also has. There is also some studies about how does it work. It seems to be that the dentin uses the light and transports the light and then shines it out of the dentin through its tubulars inside the enamel. So then we have got the light scattering, the blocking of the light, and then we have got something resulting. The resulting is that there is coming less light where the light is blocked, and we acquire the data then with a CCD sensor or photo sensor. This might illustrate also how we place it on the tooth. So they are very flexible, the arms, so there's no complaint about it. It's just too hard for the gum. And this is the way how we place it. You might see it now also on a video I did. So this is the live video you get when you place the camera on the tooth, and then just starting, you see a big caries decay outside of here. It has already reached the dentin enamel junction, so I will go to that point a little bit later, but you see that you can conclude now that the lesion is inside the dentin. Again, look at this very high contrast we receive in terms of the contrast between the lesion and the enamel, and also in terms of the dentin inside of it. So we go further on. Channels. This is the next one. You see this is a filling, and here you see also the caries lesion also reached a little bit the dentin enamel dental junction. So this is a typical indication where you might see it also on beneath the filling. Here again, the caries lesion on the second molar, interproximally on the second molar. Again, something you will observe that it's also reached the dentin enamel junction. What about the functionality? Why do we use near-infrared light? What does it mean? So, in principle, wavelengths have different indications. What we normally have between 400 and 700 nanometers is the visible light, so from blue to red. And if you go above 700 meters, we call that infrared light. And especially near-infrared light is defined everything between 700 and 1400 nanometers. It's part of the infrared light. What is the advantage of this I think what is the advantage of this near-infrared light? This is a graph which is from Daniel Fried. He is investigating near-infrared light for caries detection in art. It's a publication from 2010 where I looked into what is the what do we get out of it if we just increase the wavelengths. So on the left, on the y-axis, you see the extinction, so the lowering of light, and on the x-axis you see the wavelengths. And look at this red line. So the longer you do the wavelengths, the more transparent the enamel gets. Yeah? So the absorption to enamel lowers and the transparency rises. We can prove that through two pictures. This is the diphotic technology. I already mentioned the diphotic technology used a laser beam of 650 nanometers, which is more or less at the end where you see this graph here. Yeah, it's getting a little bit more transparent, but you see that it's quite milky, opaque, the enamel. And if you increase the wavelengths like we did with the Acnochem, it's the same tooth, the same lesion, and you clearly see that it's getting more transparent, so it's more or less a confirmation of this graph. You clearly see that it's getting more transparent, the contrasts are getting better between enamel and the caries lesion. Coming to the indications, there's a broad range of indications we can cover, or it's covered. We can see occlusion lesions, also if the occlusion lesions are inside the dentin. One of the main indications is, of course, interproximal or proximal caries lesions, as we have already seen. We also see recurrent caries or caries adjacent to fillings, which you see over here. You see the black spot on the mesial part of the tooth. Under the restoration, you also see some cracks over there, and this is also being something you will observe when you use the Diagnostic cracks on the right, left or lower right. You might also see the cracks over there adjacent to the filling. Might be also a good option to use this technology if a patient comes with unclear pain to your practice. Sometimes patients are not able to just say it's this or this tooth. I've got pain somewhere around there. And you're doing X-rays, you're doing sensitivity tests, hot and cold tests. Maybe they are all not really showing you something. Indicating the right tooth. This is the possibility to just get a better clue on it, what might be the reason for that, and if the tooth shows, if you don't have any signs, and if the tooth shows cracks, easily being displayed by the Acnochem, you can prove that by that. When we use the Diagnostic, it might be interesting what classifications we can get out of it. This is based on a study from the University in Munich from 2013. If you buy a Diagnostic, this is also included inside there. And I would like to point out two things. It is just most important is just the difference between enamel and dentin caries. And there is, I would say that there is a part from the lesion when the lesion has touched the dentin enamel junction. This is most importantly. Then we know that there is something in the dentin. Otherwise, we know there's something in the enamel. So interesting. You will observe very but very early stages of caries with the Acnochem. We've also put in here the treatment option. So if it's just only in the enamel, the caries lesion, the recommendation from Munich was just to have preventive intervention. caries monitoring. One word out of the practice I would like to add. Of course, it's your decision how you treat it. Do you treat it invasively with restoration? Do you treat it with monitoring? Sometimes it might be also interesting, or it might be also useful to do a restoration in this case. If you know that the patient is coming only 2 to 3 years to your practice, he has a lot of caries historic with his teeth, so there might be also the option to intervene with the restoration, or for example with caries infiltration for the diagnostic. If it comes to dentin caries lesions, you see on category 4 and 5, then, as I said, it has reached the dentin enamel junction in broader scale, and you can do a restoration, but you can also do, as you don't know exactly where the caries is being inside the dentin, so this is not possible. I have to say that it is not possible really. Only 1/3 of the cases we saw that you are able to look inside the dentin. Mostly you are not able to look inside the dentin. This means you should do an additional X-ray if you want to know it, where the caries is very near to the pulp, or it's only superficially in the dentin, on the first part of the dentin. This is not being possible with the Accuchem. Again, you can conclude from the picture, from the shape, to a dentin lesion. Before we start with the clinical with the clinical cases, these are the studies I summed up with a search through PubMed and Google. I found 12 studies taking about interproximal lesions, 5 with vivo and 7 with in vitro. We have got 5 a little bit less occlusion studies. We have got 1 study which I found which takes care about interproximal occlusion. Discusses interproximal occlusion means lesions, and 1 with fillings, adjacent to fillings. Let's move to some cases. Data were provided by the from Munich in 2012. This is a case where it demonstrates the capabilities for early caries detection. You see the visual findings, which you can see this more or less no sign of a caries there. Then if you place the Accuchem, you see it interproximally on distal, on the first premolar, and medial on the second premolar, on the left ring, and also medial on the first premolar. When you look to the X-ray, yeah, you might see something there, but especially if you look to the mesial part of the second premolar, so there's a tooth left on the picture, you don't really see that there is a caries lesion. As explained, the caries lesions are limited to the enamel, and therefore prophylaxis or monitoring is recommended. 2 studies I picked out from one was from Armir, laser diet near transillumination. Diagnostic is reliable and valid method of detecting in early enamel caries mineralization. In vitro study. We also have a study from Lederer from Munich, and they concluded also that Accuchem is more capable of detecting initial proximal lesions than DR. DR stands for digital radiography, and also have a higher sensitivity for dentin lesions. However, this I already mentioned, caries progression in dentin cannot be reliably determined with Diagnostic.
Dr. Emde, kann ich Sie mal ganz kurz unterbrechen?
Ja.
Können Sie in Ihrem Panel einstellen, mal kurz die Kamera an und wieder ausmachen?
Ich bin
Weil
umgekehrt.
Ihr Bild ist irgendwie umgedreht, ja, richtig.
Das ist immer noch umgedreht.
Also Sie können da auch die Kamera an- und ausmachen, glaube ich, über das Panel.
Ja, ich hab das jetzt an und ausgemacht. Das
Ich sehe
macht
es
er dann.
leider. Dort kann man, glaube ich, auch Stopcam und wieder Startcam einstellen.
Ja, ich habe Video. Nee, er macht jetzt hier. Ich habe es jetzt ein paar Mal an und
Okay.
ausgemacht.
Okay, dann wollen wir es weitermachen so. Wir drehen das dann im Recording rum.
Ja, okay. Ja.
Okay, sorry.
Eine andere Frage, Freigabe für den Zeiger. Den hatte ich, glaube ich, noch nicht eingestellt. Ich muss
Doch,
jetzt auch
doch,
kurz
wir
aus
sehen
dem.
den Zeiger. Wir sehen den
Sie
Zeiger.
sehen den, Sie sehen den
Genau.
Zeiger. Okay, gut, dann ist alles klar. Ich probiere es jetzt nochmal, ob er mich jetzt wieder richtig umdreht. Nee. Okay. So, sorry for this flipping of the image. The recording will be in the right way. So, hope you can live that I'm just now standing on my head. Okay, just moving on interproximal caries detection. Also a case for second premolar. You see that this is also more or less no signs. Maybe here in the fissure there's something. Placing the acne cam on it, it's clearly that it is just reached the dentin enamel junction. It's a big lesion you see inside the dentin. Therapies, of course, in this case. In this case, a restoration. Studies from König, two studies from König from Munich. The diagnostic accuracy of any LT is just its near infrared transillumination achieved the same level as bite wings for detection of proximal dentin caries. And secondly, there was a study evaluating detection of proximal caries lesion in posterior, and they compared different methods: visual inspection, digital bite wing, radiography, and near infrared light transillumination. I think it was in 2014. The study confirmed that visual examination alone led to underestimation of the caries burden on proximal sites in posterior teeth. The novel near infrared, this is an older study, novel near infrared light transillumination might be useful with additional caries detection and diagnostic method. This is more or less now confirmed by other studies. Also here, just an illustration what they find. The acne can find 99% of the lesions, bite wing 96, less on the same level, but visual inspection, when it comes to caries lesion, approximate caries lesion, reaching dentin only in 2%. Occlusal surfaces, we also know it works pretty fine for occlusal surfaces. You see on the left, you see a little bit sign of these of the caries lesion over there. Placing the diagnostic on it, you see that there's a black spot. Especially if it gets in cloudy, you know that it's going more or less all over inside the dentin. Placing it up, X-ray confirms a little bit, and you see a minimal intervention in doing occlusal lesion or occlusal restoration. Would like to point out two studies from Tasovka. Diagnostic was found to be most effective method for diagnosis of occlusal caries without cavitation in permanent molar teeth. So one is confirmed by the images above. Also a study from Marinova Takorova. The results obtained by the Diagnostic came very close, but the Diagnostic data was better correlating with the clinical results. The Diagnostic procedure can be judged as equivalent in the detecting of occlusal dentin lesions when compared to clinical results. Also in primary teeth, we see it is useful. The case also here, primary teeth are a little bit different from the anatomy. The enamel is thinner, sometimes also a little bit more opaque, so transillumination might not provide you these high contrast pictures you see from permanent teeth. However, it works pretty fine. Also confirmed by two studies. This was a study by Zhu from Eugene. The accuracy of the diagnostic in detecting incipient proximal caries in primary molars was comparable to that of bite-wing radiographs, and the second study, von Zirme, Diagnoscam, Diagnostic pen, and the visual examination method may be effective in detecting hidden occlusal caries in primary and permanent, so they compared both in primary and permanent teeth. I would like to add one thing for this, is just because we know that it is when you just have the change of the tooth, when the permanent tooth is beginning to resolve the roots of the primary tooth, there might be a time where the exact diagnostics might be more difficult, as the light isn't that good transported to the primary tooth, because the root, as I explained, we place the tooth pipe and tooth light sources between the roots, not between, outside the roots, and use it as a light pipe. Then the light pipe doesn't work as well as with permanent tooth, so there might be a time where you have to be patient about that. Also, a clinical case with recurrent caries around fillings. Now, on the left, on the Diagnoscam picture, this is a picture out of our daily practice. You see with the right arrows, you see black spots where the filling needs to be removed. You see the black spots here, or the black contrast. It's different to the dentin. See, it's a blue arrow, and it's different. Also, you see a small crack over there. So when you do the X-ray, you don't see too much, or more or less nothing. And if you use it for the tooth was opened, excavated, and then it was filled with the solid floor filling. There's also been found one study takes care about caries lesion adjacent to composite restoration, so it was composite, a little bit different, but they also concluded with Diagnoscam seems useful for detecting proximal caries lesions to restorations. Coming to the next point, the practice integration, how we can place it in the practice. This is an overview of doing it technically. Technically means how do we get it connected. So Diagnoscam has a USB connection, so place the USB to your computer, and it will be connected. However, there are some conditions. The one condition is, one possibility is, if you have already installed KaVo Connexio, KaVo CleanView, or Genix VixWin, then you can use it with this programs, with this software. If you have not installed that, or you would like to use the advantages of the Diagnoscam software, which is tailored to the usage of Diagnoscam, which is doing monitoring, things like that, you should install the Diagnoscam software. You have to, if you have, after installation, you have to select the patient, then connect, or before you can connect the Diagnoscam, click on the icon below, and then you can start. You get the live picture on the left, you see. And what is very nice is just you can do monitoring. So meaning on the right you see the pictures or the images you have already taken, maybe 1 year before, and you just want to see if there's a progression. You easily just pick the right picture, the right tooth. There's a tooth status over here. Pick the right picture, and then you can display the new one, the live video, and then compare it with the picture you've already taken, and conclude if there's a progression or not. There's a third option, or a second option, if you have not connected the other softwares, connects to KaVo and Xwin. The second option for if it's not connected, you can connect it also with Twain. If you're using a different X-ray source, a different X-ray software, it's not included into the package. Included in the package, I would like to mention that is if you want to use Diagnostic with VDDS. VDDS is a software or is an interface which connects you, especially in German-speaking markets, which connects you to practice management software. Then your Diagnostic is directly imported into practice management, or you can start Diagnostic directly out of your practice management software, which makes it more easy to handle. And there's also multi-user functionality integrated into this package. Next point about practice integration is something I would like to point out some financial aspects. This is from a doctor, but it's more or less an example because he stands also for other doctors which confirm that they saw an increase of their fillings, of their restorations, of the further treatments they can do with Diagnostic. He saw an increase of 40%. This comes from why? Because you oversee, just as I explained, it's as your eyes are not that reliable to detect interproximal caries, and Diagnostic helps you. Also, it helps you to just say, well, maybe we have to do use prior to X-ray. It indicates how here's the filling or here's an indication which I take care about. So another point is how to integrate it under some other financial aspects is more or less this is paying back by the more indications you see, but then it's more or less you're just working on a higher level. Yeah, it's an increase, but then you're working on a higher level. But also aspects are if just you can include it into your checkups and just charge the patient for that, or you can include it into your prophylaxis and increase the prophylaxis for that. It's very well accepted by the patient. As it is radiation free, you can use it for children, you can use it for pregnant women, and it's very appreciated by the patient to understand what's going on in their tooth, and sometimes leads also to a higher case acceptance. That as they understand it, you don't have to explain this is you do an X-ray, this is the dentin, this is the enamel. Because the patients see their tooth like they look if they're looking into a mirror. The only thing you have to mention is just this is something where we just make it like a glass, your tooth like a glass, and we look inside. So the patient is it's very easy for the patient to understand that picture. Again, I already mentioned practice integration, where to place it. We see from the market two different possibilities. The one possibility is just put it into the prophylaxis, part of tooth cleaning by dental hygienists, or you can use it for regular checkups, just as I said, looking for the guilty tooth by the dentist itself. It's depending on your practice, how you're organized in terms of prophylaxis. Do you have a prophylaxis? In some markets, I know dentists are treating alone. So might be a decision you have to take where you want to locate it and how it fits into your daily practice. It fits in both. Yeah? It fits into the prophylaxis and it fits into the usage by the dentist itself. Just coming up for the short summary, we know that it is a reliable diagnosis with Diagnostic. It's meanwhile a good proven technologies, and by a lot of studies I've showed you. we see a high specificity and sensitivity. We see that it's better comparable to X-rays. We also see it from the studies, but also from a lot of dentists who are using it, that they observe much more enamel caries, early caries, which they would not have seen on X-rays. Important is that there is more or less influence through plaque and or stain. It is just, as I mentioned, it's a different technology. It's a technology which is not based on fluorescence, on the response of light. It's more technology where we use this long wavelength, which can penetrate the tooth in a very good way and are not influenced by plaque or stain. We have got a broad range of diagnostic capabilities. We've seen approximate cases, we have seen occlusal cases, we have seen recurrent or adjacent caries to fillings. We see that it's good to use for crack detection. I already mentioned also that we have got the easy patient education, we have got motivation, we can use it for monitoring, we can use it, we can integrate it into the workflow, as I showed with prophylaxis or with the dentist itself. And very important also for you, you might know the learning curve is quite short. So the learning curve is just, it's a little bit, you have to look at to place it in the right way on the tooth. Maybe a trick which you might consider if you use it is just to not only to look from one angle, always rotate the device a little bit during you just get it through your mouth, get it through the mouth of the patient, just to have different views. If you see an indication, you might also look at it and just look for the smallest size of the lesion because of projection. You have got the ability to just look for the right projection, not like with X-rays, and just look for the right projection. You look for the small size of the lesion. In very rare cases, it might happen that the interproximal caries, interproximal tooth shines into the neighbor tooth, which might indicate caries lesion, but this will go away if you just rotate the camera, and then you see that there is no more. If it's just only an artifact, it will disappear. Yeah? So, but it's very easy. You do it once, and then it's clear for you. The learning curve is that short, as the patient can understand it also. Last but not least, to mention, it's X-ray free. So, as I said, it's just very good for patients, for children, for pregnant women, but also for all others to find in the tooth and to find caries, hidden caries lesions. Live video also comes with it, but you can just freeze the picture as you've seen and look at it on a more specific way. By that, I would like to come to the end of the webinar. Thank you very much for attending it, and now I'm open for questions, and we'll close now the webinar presentation. Thank you very much. Okay, so I start with the first question. There's a question from a doctor. Is it possible to see the pulp space using Diagnostic? No, it is not possible. It is, as I said, the pulp, the dentin is more or less not possible to transilluminate. So, and everything under the dentin also not. So there will not be a difference in we are not able to look inside the dentin and inside the pulp. This is unfortunately is not possible. This is a limitation of this technology, and maybe we don't know what the future will bring. But based on the own observations we did, we are not able to look deeper than we can conclude from the enamel shape to if there is dentin caries, but we cannot conclude how deep the caries is inside the dentin or further. When Caries detection devices, do you carry out supplement test methods to confirm? Yeah, okay. Also, the question is, when using transillumination Caries detection devices, do you carry out supplement test methods to confirm diagnosis of more clinical? Yeah. Yes, I recommend it. However, the studies in the past or during the last years confirm that it can be used more or less also alone. But to get a better clue, and of course, it is the case with every diagnostic method. The more diagnostic methods you put together, the better you're getting a clue of what's going on in terms of the disease. Yeah? So yes, I recommend to use different ones. Use visual, use Diagnostic, use X-rays. However, I could show that X-rays, you might have the chance to decrease the number of X-rays if you use Diagnostic. Is it autoclavable? Yes, but not fully. Meaning the tip you see on the Diagnostic can be replaced. You can buy new ones. I would recommend to have some Diagnostic tips inside your practice just to change between different patients. And this tip you can just can be autoclaved, but not the device, as we have got too much electronics inside there. Is it effective on incisors? Yes, you might use it, but the main indication is for interproximal or occlusal caries detection in premolars and molars. You can use it. I tried it, but of course, just showing, especially to your patient, caries lesions, you can do it for incisors also, just using it with a mirror or just placing a bulb behind. That works. You can just bend it around, but you will let a little bit the clear vision. For you, you might understandable, but it's not. It's made for premolars and molars. Can we find exact depth of caries? Yes, this has been confirmed by some studies. These studies confirmed that the enamel lesion always corresponds to the size you can see with the Diagnostic of the enamel lesion corresponds with the clinical situation. There was a study in Munich where they investigated this intensively. And they because there were some signs from the literature that there's no correlation, but we could clearly show that with different studies that the size of the lesion always corresponds with the size inside the tooth. As I said, dentin, we are not able to look inside. Can you see external or internal resorption, particularly anterior teeth? No, this is not possible. So can we see external or internal resorption, particularly in anterior teeth? I have not seen that. I have not tested it. So I think it will be hard. Internal resorption is not possible. We are not able to look under the gum. Yeah? This is the limitation of the device is enamel above the gum. Yeah? Can be used safely with pregnancy? Yes, it can be used safely, as I already said. It is just no radiation. It's an absolutely non-hazardous light we put on the tooth. As I said, at the moment, we can use it. Yes, I cannot see this question. Let me see. So there's also a good question. As I understand, at the moment we can use it only for diagnosis of cavities, but I will not be able to check if the cavity preparation was performed completely, as I will not be able to. Yes, this is a good question. Can we use the Diagnostic to check our own preparation? Yes, we can do so. So the question is, if you have opened up the cavity, place the camera on site, and then you will see if you have excavated all caries. However, I would be patient with that because sometimes you have got parts of the caries which have already been remineralized, which are hard in its structure, and from my understanding, we should just do not remove this part of the lesion, and then. But you might see this also in the diagnochem as black spot. You have to, so you can do it, but you have to just check it with different means if the lesion is the surface is hard enough, or if it's soft. If it's soft, yes, you can check it with the diagnochem. But it's not an official indication. This is something I reply now on what some dentists are doing. Is it available in KSA? Yes. How many tips with the Diagnostic? So we have got the package comes with two different tips. So it comes with two tips, and they are delivered, but you can, of course, you can buy additional ones. Sometimes dealers have special offers where we get additional tips to that as well. Okay, so I think I'm done with all the questions. Thanks you very, very much for your interesting question, for your interest at all. And by that, I would like to close now the webinar. Thank you also to DTI who hosted this webinar and for the support by Hannes Kuschig.